So when the body is sensing, it is important because when you sense only, then you decide about the level of secretion. So if you are sensing a hormone level more, what will happen in that regards? If the body senses that the level is more, then it's actually there. What sort of disorder will you see? Deficiency or excess?
So if the body will sense more, that is the kind of activating, we will say, and it will cause the level will decrease.
So if you are sensing more, the body will say you are already there in more, so you will develop into the deficiency state. If you are sensing less, you will develop excess. Classic example is what we talk about the calcium sensing receptor. Inactivating mutation causes hypercalcemia. Activating mutation causes hypocalcemia. And we discussed about what really regulates the sensitivity. So what we discussed last time also was that the pancreas beta cells are basically linking ATP to insulin release, and the main mediator is a potassium channel. So if your potassium channel has a activating mutation, you will have thinking what will happen in that scenario. So you will start having hypoglycemia because your insulin secretion will become too less. If you have a problem of inactivating, you will have diabetes. So this is a classical example from that perspective. So we have a 10-day-old neonate with hypoglycemia, Dr. Dhwani. Birth weight was not very high. GIR is 12 milligram per kg per minute. So high glucose requirement, non-ketotic, non-reducing substance. So broadly, what are you thinking of here? Yeah, so this is high GIR 10-day. So it is out of that 48-hour period. The GIR is very high, non-ketotic. So there are very few differences. So it basically means it is basically hyperinsulinism in that perspective. The growth hormone is normal, cortisol is slightly low, which may be an exhausted response. Insulin is 1.8. So what do you think about this? So do you think this insulin is significant for the level of hypoglycemia? Everybody who has got a hypoglycemia should have no insulin. They should have no business to produce insulin. So 1.8 insulin is definitely high. So this is hyperinsulinism. Now, Dr. Manoj, what type of hyperinsulinism are you thinking this is there?
So birth rate is 2.9, so it can't be the antenatal associated problem. And birth rate is means it is not high. So some syndromic causes we can rule out. So we can means transient form of the hypoglycemia.
Okay. So this is clearly maybe a milder forms also, which may be there. So again, the sensing which may happen at the level of glucokinase may also cause the similar picture. So one, we talked about the potassium ATP effect. We also need to understand what happens with glucokinase. If you are sensing glucokinase more, body will think that your glucose level is on the higher side. In that perspective, you will produce more insulin and you will develop hypoglycemia. What is the key feature of GCK associated hyperinsulinism? So if we go back to this case of beta cell sensitivity, and we discussed about that, how your GCK activation will have an effect. So in this scenario, you have got a milder form. So you said potassium ATP channel defects are less likely. So this happened to be a glucokinase activating mutation. So what is the characteristic feature of this form?
Mainly it is causing the fasting hypoglycemia.
Fasting hypoglycemia. You're talking about the other way around. You're saying fasting hyperglycemia it was causing. So you think it's the opposite, but it's not opposite in that form. So what will happen if you reduce their sugar levels to a great level? What will happen? How low will their sugar levels go?
Means it is at the low level, the threshold will means it will not increase that much. So they don't develop that much hypoglycemia.
So just the next case where I'm talking about that is that if you have a glucokinase deficiency, in that setting, the body says, okay, my glucose levels are on the lower side and then insulin is not produced. So you develop fasting hyperglycemia, but that as soon as the sugar levels go a particular level up, your fasting hyperglycemia comes down and the level becomes normal. And that is the glucokinase deficiency MODY 2. This is the mirror image of MODY 2. You have hypoglycemia, but if your sugar level goes below a particular level, you have suppression of insulin production. While if you have a potassium ATP channel defect, continuously you will keep on producing insulin, whatever your level of sugar. Simply speaking, you can say this is more like a proximal RTA, which is a self-limiting condition. Distal RTA, whatever level acid production is basically the problem with acid excretion, you will persistently have acidosis, you will have much severe disease. So that is why this is self-limiting. Now, if your insulin production is inhibited, what will happen to ketone? So can they produce ketones?
No, sir. Insulin is not there and ketone should be absent.
If insulin is there, then ketone should be absent. But at a particular level, when they stop producing insulin, they can develop ketosis. So this is an interesting form of sensing where the body will say, okay, till a level, they will behave just like a hyperinsulinism. But beyond a level, body will say, okay, enough is enough. I will stop producing insulin. As soon as you stop producing insulin, they may have ketones. So they may have a transient ketosis and then the body will recover from that perspective. So this is a self-limiting form. So this is the glucose sensing problem that we are talking about in that perspective. Second case, Vibha, 12-year-old girl with high sugars on routine testing. Fasting sugar was 130. 2-hour reading was just 14 above. It was just 144. Now, hemoglobin A1C was pretty much like 6.7. And there was a strong family history in the mother, sisters, grandmother. Everybody had mild diabetes, which worsened during pregnancy and then became normal. So what do you think you're dealing with? Is it, and this child is non-obese, lean child, no acanthosis. So is it type 1 diabetes? It is unlikely to be type 1 diabetes. Is it type 2? So lean child, so unlikely to be type 2. So there is a strong family history. You are thinking of MODY. Now, which type of MODY? MODY 2. So there are two types of MODY. One is a transcription factor MODY, which goes into our other group in which your production of insulin is defective. Here, there is no problem in insulin production or action. The only problem is in glucose sensing. So glucokinase is a unique sensor of glucose in the body. In the first case we discussed, it was sensing too much. Your glucose is low, body is saying, okay, my levels are very high. Here your glucose is high, it is not sensing. So this is a sensor defect, and that is why you will have this very limited gap between the fasting and PP. Now, why does glucokinase act as a sensor to glucose? And how is glucokinase different from hexokinase? So the normal glucose phosphorylation happens with hexokinase, but here we are talking about glucokinase.
So both glucokinase and hexokinase have different Kmax values.
Good. So what does it mean? What does it imply?
They are the concentration.
So glucokinase, first of all, is there largely in the beta cell. Its expression is not elsewhere. So if it is everywhere, then it is not a useful thing. Its role is only to tell, okay, you have this much glucose, which is a marker of ATP, and then you will talk about going to the Krebs cycle from there. So it depends upon the Kmax. So it will act at a higher concentration. If your concentration is low, it will not get activated. That is why you don't have insulin secretion. Otherwise, if you link to hexokinase, that even at lower level, you will start producing insulin. So the major role of glucokinase is sensing the glucose. And that is why your sensor problem, as we discussed, the sensing is less, you will develop mild diabetes. Sensing is more, you will develop mild, quote unquote, not that mild, hypoglycemia may also happen, in which you can have ketoacidosis in that regard. So this is just to highlight these cases. You can, of course, go into those specific modules later. The aim of these sessions is mainly to increase the understanding about how diseases can happen, and you can speculate from there. Now, the second important factor, so one we said glucokinase is a glucose sensor. Calcium is a very important compound in the body. You have got a specific sensor for the calcium, which is the calcium sensing receptor. Now, calcium sensing receptor basically is acted upon by calcium and magnesium. And what it does, if you have more calcium in the body, Dhani, what will you want to do? What will you tell to the different organs? Okay, do this, do this. Okay. So you are plenty. So which hormones, what hormones will you want to do? So what will you do to PTH? So you will want the PTH level to secretion to be going down. What will you want to do to the kidneys? Urinary excretion of calcium. So you don't want hypercalciuria, you want to lose the calcium. What will you do to the thyroid? So calcitonin, basically you want as a hypocalcemic hormone, calcitonin, but that's physiologically not important, but mainly it is the PTH. So in a way, nutshell, if I talk about this, calcium sensing receptor is instructing the parathyroid to decrease and kidneys to increase in that perspective. So if you have, Dr. Manoj, an inactivating mutation, what will happen?
Inactivating mutation is there then. Kidney is not sensing the calcium, so there will be the hyperactivation of the PTH and there will be the hypercalcium.
So basically what will happen, your PTH body will say, okay, I don't have any calcium, I keep on giving calcium. Kidneys will say, okay, we don't have any calcium, let's conserve calcium. So you will basically have a scenario of hypercalcemia with hypocalciuria. Everybody who is hypercalcemic should have hypercalciuria. Body should lose high serum, high urine calcium. But if you have this paradoxical situation, you know it's a calcium sensing receptor defect. Now, if you have the opposite picture, Dr. Vibha, what will happen if you are activating? So basically what will happen, activating mutation, your calcium sensing receptor is more, PTH will come down. So hypocalcemia will be there, but kidneys will be causing loss of calcium. What is the significance of this condition to identify this condition? Suppose you have a patient who has hypocalcemia, hyperphosphatemia, and PTH is low, you know it is hypoparathyroidism. Why do you want to diagnose this condition? In the sense, so suppose you have hypoparathyroidism versus a calcium sensing receptor defect, how is the treatment different? Which will be lower? And for the calcium sensing receptor mutation, you keep at the higher side.
In the this.
So let's ask in a different way. You've got three people. One who has a normal PTH, second who has hypoparathyroidism, and third who has a calcium sensing receptor defect. Everybody's calcium is 8.5. Who will have the maximum calcium excretion in the urine and who will have the minimum calcium excretion in the urine? And fourth is PHP. Let's put it 4 people. Normal, you have decreased his calcium somehow. Pseudo-hypoparathyroidism, hypoparathyroidism, calcium sensing receptor defect. Most likely to develop nephrocalcinosis, number 1.
Nephrocalcinosis in the calcium.
Because even at lower calcium, their whole blood calcium to urine calcium to blood calcium curve is shifted to the left. For any given level of calcium, they're losing more calcium. So they will develop hypercalciuria and nephrocalcinosis. So you want to keep the level 7.5 and 8. Even at 8.5, they will develop polyuria, abdominal pain, and other things. Next comes hypoparathyroidism. Because parathyroid is also a conserver of calcium. If you have hypoparathyroidism, you will lose that calcium. So there you want to keep 8 to 8.5. Third comes pseudo-hypoparathyroidism. Because the relative efficacy of PTH in the urinary calcium is preserved because of a biallelic expression. We'll talk about genetics much later, but relatively they will not develop hypercalciuria. Of course, normal person will have he'll have 0 calcium coming in the urine in that perspective. So this is important to identify, because if you have somebody who looks like hypoparathyroidism, do a urinary calcium right at diagnosis. If he has hypercalciuria, do not give a high dose, and they will become very sensitive to develop nephrocalcinosis. So this is something to remember. Similarly, if you have a calcium receptor antibody, you can have an activating and an inactivating antibody. Just like you were talking about the insulin antibodies and the thyroid and the TSH antibodies, they can also cause autoimmune hypoparathyroidism because of this mechanism. So they can cause inactivating or activating, both of them can happen. So Dr. Manoj, 12-day-old girl with irritability, with dehydration, calcium is 18 and PTH is 120. So diagnosis is clearly hyperparathyroidism. Now what will be the next step you will like to look at?
Well, This is the hyperparathyroidism. So before stamping it, we need to do urinary calcium ratio.
So this will help you to identify the cause in that perspective. So urinary calcium to creatinine was relatively low for the infant and much low for the level of calcium. So you have high serum, low urine calcium. So this is a calcium sensing receptor defect. Next step you will do. Any simple test that you can do which can confirm the diagnosis? How will it help? Not in the child. USG will tell you not in the child, somebody else. Parents. So you have to do in the parents because there are 3 different types of neonatal severe hyperparathyroidism. One in which both parents are affected. Now, if your calcium is 18, you expect that type of defect usually. But there could be an unusual scenario in which the father is affected and the mother is unaffected. So why do they develop hyperparathyroidism and what is the course there?
Father is unaffected and
Father is affected, mother is unaffected. So there is a autosomal dominant form. If you have autosomal recessive form, both genes are gone, they will have very severe lifelong. You have to do a parathyroid surgery. Now, if I say we have given parents high calcium was there, but suppose I would say that father's calcium was high, mother's was normal. Do you think surgery is required immediately or you can think of something else?
Father is high and mother is normal.
Vibha?
So, father,
So father's is high, fetus calcium will be high or low?
Yes, fetal calcium will be high because
since mother's calcium is low and
so fetal calcium will be high and you will have parathyroid hyperplasia also. But as soon as the child comes out, it's a benign defect. Essentially, in a normal scenario, you should not have a problem. Father also did not have a problem. Here also, both parents didn't have a problem. But because of the lower, even normal maternal calcium is being sensed as low by the fetus, the parathyroid becomes more. So that becomes a transient form of neonatal hyperparathyroidism, and that is important. The same is very relevant in a child who has GCK deficiency. Suppose you have a child who has a GCK deficiency and mother has a normal, what will happen? Will the child develop macrosomia or not? Mother is normal, child has GCK deficiency, what will happen? So child which sense mother's sugar as low, GCK deficiency, na? So what will happen? So there would be glucose basically production will be less from that perspective. Na? So there will be GCK deficiency, you will behave like diabetes in that perspective. If both mother and the child are affected similarly, you will have no problem. Mother has mild diabetes and child has a normal situation, what will happen, Vibha? Then you will develop macrosomia. If mother is not normal and child is GCK deficiency, you will have IUGR. So this is an important concept to remember. You get the point? So basically, if the child is GCK deficiency, he is having a problem in sensing in that regards, and mother's glucose basically is normal. So they will be considered to be low in that perspective. If mother's sugar are high, you develop macrosomia. If the baby feels low, they will develop IUGR in that perspective. So again, if you understand this functioning, it becomes very easy to identify many of these disorders. You don't need to understand everything now, but this is more for concept that there are sensing defects which can make a huge difference. So this is a sensing abnormality in which you have got this hyperparathyroidism, which is there, and you have hypocalciuria. Yeah. Yeah. So if mother also has a GCK deficiency, then mother sugars will be high. So those high sugars will be treated as normal for the child. It is not zero. So the curve of that receptor is shifted to the right side. If both the genes of GCK are defective, that is the most severe neonatal form. But otherwise, GCK deficiency is a mild phenomenon which nobody will pick up. So you will say, okay, at sugars of 130, you will feel it like 100. Some people say, I am tolerant to cold. So they are happy to be at 6, other people are happy at 10. But if it becomes 0, then everybody will have a problem in that perspective. So that is something to understand in that perspective. Okay, so basically it is relative to the level of what the child should have in that perspective. So 8-year-old girl with cramps, serum calcium is 7.6, phosphorus is 6.5. So Dr. Radhwani, hypocalcemia, hyperphosphatemia and PTH is on the lower side. Diagnosis. So what will be the next step to look at?
Urine calcium.
So hypoparathyroidism, calcium and calcitriol was started. Now complaints of irritability and polyuria. So here it was found that child actually had hypercalciuria. So this is the message I was giving, that you should have checked it right at the beginning, because if it is checked later on, then you may develop this hypercalciuria. So again, 3 conditions: PHP, HP versus calcium sensing receptor defect, lowest dose in calcium sensing receptor defect, then hypoparathyroidism, then pseudo hypoparathyroidism. This is what you need to be aware about. And if you understand the functioning, you will identify in that regard.